we're just about to have a talk on diabetes from Professor Ewan Pearson, who's in the School of Medicine. And I'm not going to say anything more, but I gather you're going to kind of introduce how you came to Dundee and tell us about diabetes. Thanks.
I need to introduce myself and why I came to Dundee, or how long I've been in Dundee now for about 11 years. For those of you who can tell from my accent, I'm not Scottish. And I have to say, I came to Dundee 11 years ago because of the diabetes research that's going on in Dundee. That's why I came up from the south, and that's why I'm still here, other than, of course, the lovely weather that we have. So, are we ready to kick off? Yep. Yeah. So I thought I would start by asking you to all look around you and look around yourselves at each other. Okay, don't worry, you're not going to have to introduce yourself to everybody, but just have a look and notice how different we all are, okay, because that is the key part of this talk. Okay, we are all different. There will no doubt be a number of people in the audience with diabetes. So I would predict that there should be about 5–6% of us with diabetes here, but given the title, I suspect we've got an overrepresentation of people with diabetes. And yet, the thing that fascinates me when I look after patients with diabetes is how different everybody is. When they come through the clinic door, then they're very different. And if you look around us, we've got young people, we've got people of my age, young, and then we've got older people here as well. And then there's people who are more overweight, slimmer, we've got people of different ethnicities. We've got hugely different population. And why people get diabetes and how we manage them really matters when we need to think about why people are different. And actually, if you tunnel down if you could look at people under a microscope more and start looking at their blood, you'd see that actually two people that look quite similar are actually very different. They're very different in terms of all the chemicals floating around in their blood, and they're very different in terms of their genetics. So, the issue with that is that all of our current approaches to how we manage pretty much every condition doesn't assume difference, it assumes that we're similar. It groups people together to give us an average. So actually when we give people drugs, we don't take any account really of how people differ from each other. So when we think around how we look after children, children obviously start very small and they grow big. And as they grow big, we adjust the dose of what we give them such that we give them the right amount of dose for the size they are. As soon as they get to 16, that we stop that. We pay no attention to whether or not someone is twice as big as someone else. And yet, we just give the same drug. And that, even worse than that, because of the fact we don't like to change the dose according to weight, and we do for some drugs, but mostly we don't, because of that, the drug companies design the drugs to be designed to be as safe as possible, and therefore they don't maximise the efficacy. So for drugs that may work well in some people if you give a bigger dose, you don't give a bigger dose because on average you're increasing the risk of side effects. So we don't do that right. And the other thing that we do, that I don't think we do well, is that when we treat people, we just have a stepwise approach to how we treat. So talk about diabetes, this is a talk about diabetes, and I'll talk about these drugs a little bit more. For diabetes, we have a very simple guide. It says step 1, well, diet, lifestyle. Step 2, metformin. Step 3, add another drug, any drug. Step 4, add another drug. Step 5, insulin. Okay? And there is nowhere in that that says, well, hang on, if you're this sort of person, get this drug, don't give this drug, because we don't really have the evidence that tells us how we should treat different people differently. Okay, so that's what we're talking about today. So the answer is any number of terms that you may have come across, and these terms change with the trends over time. So you may have heard about individualized treatment, personalized treatment, stratified treatment. The latest buzzword is precision medicine. Okay, and that's why this talk today is around precision medicine in diabetes. So what is precision medicine? So And it's pretty obvious, really. It's around being more precise in how we treat patients. And it really came into fruition about 2 years ago when President Obama announced the Precision Medicine Initiative in the US. And he pumped billions of dollars into the Precision Medicine Initiative in the US. Now, much of that has gone into cancer, and we can touch upon that later if people want to talk about that. But there is a lot of investment now within Europe and within the US to try and help us find better ways to manage people more precisely. Okay. So precision medicine is very much around healthcare that's tailored for you. And the definition is an emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment and lifestyle for each person. So, as I say, it is simply around trying to think around individuals and tailoring treatment for individuals. So, what I want you to do now is just think about a family member. This family member is going to be roughly a 65-year-old man. Okay, I'm going to call him Jim. You may know who this might be within your family. And I'm trying to make this personal because I think there's an important message here in terms of how we manage our patients and maybe how we don't manage our patients or our nearest and dearest as well as maybe we should do. So think of Jim. So 65, and he has a stroke. He's admitted to hospital, and as you all know now, if you're having a stroke, a brain attack, you get to hospital as quickly as you can, just like a heart attack. And so Jim has a stroke, he gets whisked up to Ninewells, and he gets given the clot-busting treatment, and he does very well. There's a really good response to that. So to the degree where actually he's left with no obvious deficits from his stroke. So, there's a whole load of pills that he will now be given because he's had a stroke. Now, some of the pills I'm not going to talk about, but blood pressure pills, for example. But he will be given a pill, currently, if he's admitted to Ninewells, he'll be given a pill called clopidogrel. Some of you may be on this, it's quite a common pill. Now, clopidogrel is a bit like aspirin, it's like what we might call the super aspirin. It's been around so long now, it's really cheap, and we give them out to everybody who needs anything to try and stop platelets clotting, the blood clotting. So he's given clopidogrel, and we give clopidogrel now to everybody who's had a stroke who doesn't have any reason not to have any treatment like that. But what we know about clopidogrel is that it is broken down in our bodies. In fact, it's activated in our bodies. It's what we call a prodrug. It's activated to an active drug. And it can only stop clots if it's activated. So we know that about 25 or 30% of us carry a genetic variant that means we don't break down clopidogrel, we don't activate the drug. So there's about 25% of us who clopidogrel doesn't really work very well in. And in fact, a colleague from Ninewells, Alex Doney, who's actually one of the stroke physicians in Ninewell, has done a study of using data that I'm going to talk to you about later, looking at the recurrence risk of having another stroke. So Jim, who's done very well, is given his clopidogrel. If he's one of these unlucky 25%, which is a quarter of us, then his risk of having a recurrent stroke is really very high, 80% within a year. Whereas if he's the rest of the population, 75% of us who metabolize clopidogrel normally, his risk of having a recurrent stroke is as low as 30%. So that's a huge difference on the basis of his genetics. At the moment, we don't actually do any genetic testing when we think around starting some of these drugs. Let's imagine a scenario where we know his genotype, we know that he is one of these 25% of people. And I'm going to come to this later in the talk around how the future might look. But let's think how the future might look for a minute. And my colleague, Dr. Doney, goes to prescribing clopidogrel, and he goes into the computer system to type in clopidogrel, and it pings up, alert, this person is carrying a poor metabolizing variant in cytochrome P452C19, that's the gene. Don't give him clopidogrel, give him another drug which works just as well. It's a bit more expensive, which is why we don't use it. But it works just as well, and therefore it reduces his recurrent stroke risk. So, as I said, Jim's going to get loads of drugs. People who go into hospital, sometimes on no drugs, who have a stroke may leave hospital on 4 or 5 different drugs. So he's going to get a statin as well. We all know and love statins. Everybody, they're pretty much in the water these days. Now, some of you know that statins cause some side effects, actually quite rarely, but they can cause muscle aches and they can cause severe muscle problems. So Jim is given a high-dose statin, 80 milligrams of a drug called simvastatin. But Jim's pretty unlucky because not only is he 25% who carries this poor metabolizing for clopidogrel, he's also someone who doesn't really transport simvastatin very well. It has a variant, a genetic variant in a transporter called SLCO1B1. And that markedly increases his risks of having severe muscle problems, and actually quite dramatically increases risk of having muscle aches and pains on simvastatin. So, wind forward to our future, my colleague Dr. Doney prescribes him simvastatin 80 milligrams, and he goes, no, alert, this person is not, is got a variant in SLCO1B1, he should be given a different statin. Okay? I could go on. So Jim's pretty unlucky because maybe he develops some sort of severe infection, he gets quite a bad problems with pain, and he's given codeine. You know, we take codeine now in cocodamol a lot of the time. I don't know whether you knew, oh, let's just, I've skipped a bit, here we go. That, yes, so about between 5 to 10% of us don't actually metabolize codeine at all. And therefore it doesn't work, because codeine is another drug that has to be metabolized to be active. So I don't know how many of you take cocodamol, but potentially 1 in 10 people in the room here will take it for no value whatsoever. And there are people that are given codeine and have no pain relieving benefits from it. If we knew their genotype, of course, we wouldn't prescribe cocodamol or codeine, we'd use other pain-killing drugs. So, I could go on and on and on in terms of the potential different drugs that we could give Jim in managing his stroke, where we should be able to target and tailor the treatment a lot better than we do. So, I mean, and some of the what I've given you is examples where I think we can make a difference, but we're not actually implementing this. There are examples of where we're implementing things already routinely, and we're testing people's genetics, or we're testing genetics of, for example, cancer tissues. So the area where precision medicine is really impacting now is not in stroke disease, it's not in cardiovascular disease, it's in cancer. And it's now routine that if someone develops cancer, the cancer tissue is tested, is sequenced for the genetics, and the genetic variant is used not in every cancer, but in quite a few cancers now, to guide what treatment is given. And that is now the mainstream medical practice. But I'm not going to talk about cancer, I'm talking about what we would think of as common complex diseases today, like diabetes, blood pressure, and those sorts of things. So this is a talk on precision medicine in diabetes. So I thought I ought to now talk about diabetes. And I'm going to start with the simple facts, because I don't know at what level everybody's at in the audience. So firstly, what is diabetes? I'm not going to ask. Please, by the way, please do interrupt and ask questions if there's anything that I'm saying that you want to interrupt for. But so what is diabetes? Diabetes is actually really, really simple. It is just an elevation in the blood sugar. That's all it is. Okay. and it's an elevation in the blood sugar above a particular level. So if your fasting blood sugar is 6.5, you don't have diabetes. If your fasting blood sugar is 7.1, you have diabetes. Okay? So anything above 7 fasting is diabetes. So that's how you will be diagnosed with diabetes, those of you in the audience with diabetes. However, that simple way of diagnosing diabetes is probably what makes diabetes really complex, okay? Because we make a very simple diagnosis based on blood sugar, and we ignore why someone has diabetes. Essentially, we ignore the reasons as to why someone's blood sugar is high. Now, we don't always ignore the reasons why someone's blood sugar is high, and you will no doubt have heard about type 1 and type 2 diabetes, okay? So when we think around why someone got diabetes, most of us, most clinicians, most general practitioners, actually most diabetologists will say, is it type 1 or is it type 2? Okay? And the reason we think around is it type 1 diabetes is usually because someone's presented and they're young and they're slim and they've got very bad symptoms and they may be very unwell, and that points us to thinking that someone's got type 1 diabetes. The reasons we tend to think around someone having type 2 diabetes are that they tend to be a bit older, maybe a bit more overweight. But that is where we've gone wrong, because we don't ever do any tests, or at least historically we don't, and most of the time we still don't. Other than checking a blood sugar, we don't ever do any tests to find out why someone's got diabetes. We don't really ever test to find out if someone's got type 1 diabetes. So if someone looks like they've got type 1 diabetes, they're young, they're slim, they're presented hospital unwell, we think they've got type 1 diabetes. We give them insulin, and they take insulin for life, okay? Without any diagnostic test. And I don't think there's many fields in medicine now where we make that sort of dramatic decision without doing any diagnostic tests. The type 2 diabetes is even worse, because actually when you stop and think around what type 2 diabetes is, it's basically diabetes that we can't explain in any other way. So it's diabetes that's not type 1 diabetes. It's diabetes that's not any other rare type of diabetes. It's diabetes when we don't know. And that's why when you look at people with type 2 diabetes, we have a huge spectrum of people. We have people who are quite young. We have people with type 2 diabetes in their 20s or even in their teenage years. We have people who develop type 2 diabetes when they're 85. And we have people of all different ranges of BMI and ethnicity. And yet, they've all got type 2 diabetes. And what I would argue is that because we've been so simple in how we define diabetes, actually we're really ripe for precision medicine, because all we have to do is start thinking a little bit more around why people have got diabetes, do a few tests, think about why people are different, and we should be able to give people the treatment that fits their type of diabetes. So it may be that in 10 years' time we don't have type 1 and type 2 diabetes. We could call them whatever we want. It might be type 3, type 4, it might be type 2A, 2B, 2C, 2D. We could have 10, 15, 20, 30 different variants of diabetes, all of which we manage differently. So that's certainly my vision of where we will go with diabetes. And purely on the basis of the fact that we have just been really simple in how we manage diabetes over the years. So, what about precision medicine? What do we know now around how we might tailor treatment in diabetes? So I've given you one already. I've given you type 1 versus type 2 diabetes. So that is maybe precision medicine or stratified medicine, okay? It fits, it's dividing diabetes into different groups and giving people different treatments. So there isn't really anything too fancy with the concept of precision medicine. So what else do we know around what simple things matter? What's really interesting is that we know very little. So if you take somebody with type 2 diabetes, whatever that is, but let's assume that we've got someone we think has got type 2 diabetes. We don't have any evidence, really, from the trials that says, well, this person's BMI is over 35, they should get this drug or this drug. And that's because, again, the clinical trials try and lump everyone together. They take 1,000 people with type 2 diabetes and they give them drug A versus placebo, and they show that drug A works in 1,000 people with a range of different treatments. And what they rarely do is then go and interrogate that data and find out actually it only works in people who are Asian or who are white European or who are BMI over 35. So what we've been doing recently, and this is a UK-wide consortium that I'm involved in with quite a funky name called the Mastermind Consortium. So we've been actually getting hold of all the trial data. What's quite good at the minute is, partly because of public pressure and lots of bad press that pharma have had, they are making all of their trial data available. So as a researcher, you can apply to any of the drug companies the minute any of their drugs now comes to market, and you can say, we'd like to analyse your data, please. And they give us access to data, which is amazing. And it does now give us the opportunity to get hold of all these trials that have been done in diabetes and actually start reanalyzing them. And we've been asking some really simple questions, and asking around, what about if you're male or female, and if you're, and I'll use the term obese, medically being a BMI over 30 versus non-obese. And how does that influence which drugs you get? And actually the results are really striking. So if you are female and your BMI is over 30, you will respond really, really well to a drug for diabetes. It's a drug called pioglitazone that some of you may have heard of, some of you won't have done. It's not used so much, but it works brilliantly in women who are overweight. If you are a slim man, you will respond far better to a drug called a sulfonylurea like gliclazide. Okay? And that's a drug we've used for years, but it works much better in slim men than it does in overweight women, where they should be getting pioglitazone. So just by reanalyzing the trial data, we can start to stratify how we treat patients on the basis of how they should respond to treatment. Doesn't, of course, mean to say that someone who is overweight and female is going to have an amazing response to pioglitazone. It does mean that that group of women should respond better to that drug. We're now running a trial within this mastermind consortium called TriMaster, and we're actually taking this story further, and we're looking at enrolling people with diabetes, and we're giving them 3 drugs in turn. Not just one drug like the traditional trials do, 3 drugs crossed over in a year, and we're looking at which is the best drug for that person. And we're hoping to try and understand what the genetics is, or what are the determinants of why someone should get one of those drugs over the others. So in years to come, we don't have to do a trial of 3 drugs. We can just say, because of X, Y, and Z, you should be given drug A, not drug B. So, what about genetics? I talked a little bit about genetics when I was talking around the stroke data and the clopidogrel drugs and the statin drugs. Let's have a little think about genetics in diabetes. So I'm going to introduce you to a patient of mine who, for the sake of this talk, I'm calling Sarah. So she was diagnosed with type 1 diabetes at the age of 18. Her mum had type 1 diabetes, and her mum was diagnosed at 23. Now Sarah had been diagnosed with type 1 diabetes and treated with insulin for 20 years, and was doing actually pretty well. She was managing her diabetes pretty well. But 20 years of diabetes, 20 years of insulin treatment is clearly a big undertaking, and maybe she was starting to get a few complications from her diabetes. Now, when she moved to the local area, she moved to an area where we have an interest in diabetes and etiology of diabetes and genetics of diabetes. And we thought, well, that's interesting, you and your mum had type 1 diabetes. And like I do, I always ask the question of every patient I see, was the diagnosis right? It only takes me about 5 seconds to think that every time I see somebody, and most of the time, of course, the diagnosis is right, but just every so often we find people who've been misdiagnosed. So she was diagnosed with type 1 diabetes 20 years ago, and she was producing plenty of insulin, which after 20 years of having type 1 diabetes is unlikely. And we can do blood tests for antibodies, because type 1 diabetes is an immune condition where your own immune system attacks the pancreas. And we did those tests and found there was no evidence of antibodies. So she's got a family history of diabetes, and she's not looking like she's got type 1 diabetes. So what we can then do is think about, well, does she have an unusual genetic form of diabetes? And what we know now is that about 3 or 4% of people with diabetes diagnosed under 30, it's a small amount, but that's 3 or 4% of people with diabetes diagnosed under 30, don't have a genetic form of diabetes. So we were able to test Sarah, relatively simple test, relatively cheap test, and we found that she had a genetic variant that caused her diabetes. She actually had a condition called MODY, maturity onset diabetes of the young. Knowing that, and knowing what we know about that type of condition, we know that patients with MODY don't necessarily need insulin treatment. We know, in fact, from studies I did about 15 years ago now, scarily, we know that actually these patients can be managed with sulfonylurea tablets, simple tablets. So Sarah, who'd had diabetes for 20 years, type 1 diabetes, we could give gliclazide tablets to, take her off insulin, and she's doing brilliantly. Okay? So, another story. Fiona, obviously I'm making up these names. Fiona was diagnosed with type 1 diabetes at 3 months of age. She'd been on insulin for 30 plus years when I met her. Now, you don't get type 1 diabetes at 3 months of age. Okay, if you think about the process of type 1 diabetes, it's this immune process. You have to develop antibodies, you have to destroy your own insulin producing cells. You don't really get type 1 diabetes before 6 months of age or even a year. If you get diabetes that early, it's likely to be genetic. Okay, so I was involved before I came up to Dundee in finding some of the genes that cause this form of diabetes. And we know that that if you're diagnosed at that age, you're actually highly likely to have a genetic defect in a particular part of the insulin-producing cells, called the potassium channel. So when I met Fiona, we did the genetics. We found her to have one of these genetic variants. And the other thing that's fascinating about this genetic defect is it's a defect in the potassium channels, and that's where these sulfonylurea tablets that I keep mentioning, that's where they work. So we were able to give Fiona gliclazide, sulfonylurea tablets, and take her off insulin. So again, after 30 odd years of being, in quotes, type 1 diabetes. So those are two extreme examples, but as I just said, that's 3 or 4% of diabetes. And I've told you earlier that we don't test for type 1 or type 2 diabetes, we make clinical diagnoses, and because we make clinical diagnoses, sometimes we get them wrong. So I'm a huge advocate that we ought to be doing some proper diagnostic tests in diabetes, because it does sometimes, not all the time, but it does sometimes change how we manage patients. Interestingly, and this is me maybe getting a little bit political, interestingly, there's whole areas of Scotland that don't have MODY. Okay? They don't have any genetic diabetes. So that's either because they really, genuinely are a little bit odd and they just don't have genetic diabetes, or it's because the doctors don't test for genetic diabetes. Okay? And I know there's health boards in Scotland that don't test. So what we are trying to implement now is a national programme where we, using our diabetes registry, we identify everybody diagnosed under a certain age, and we run some diagnostic tests and we do the genetics. So hopefully, my vision of the future again, but hopefully in the not too distant future, in 5 years even, we'll have got rid of that inequity across Scotland. So, How are we doing for time?
3 more minutes.
3 more minutes? Wow. Okay, I better go fast. Am I allowed 8 more minutes?
We'll run out of time for questions.
Okay, so what about... Oh, okay, gosh, we have run out of time. Okay, what about type 2 diabetes? So I'm going to be quick and talk about the common type of diabetes. Diabetes that accounts for probably 90% plus of diabetes. There's a commonly used drug that those of you with diabetes will have come across called metformin. Okay, so we are really interested in why people respond well to metformin and why people don't respond well to metformin. We've been doing genetic studies in Tayside to look at that. And we've identified 2 genetic variants that determine how people respond to metformin. And I'm not going to say anything more about that because I'm going to run out of time. Because actually I think what's more interesting is with metformin is that it has some fairly significant side effects that some of you may have come across for those of you who take metformin. Metformin affects the guts. It causes bloating, diarrhea, abdominal pain. And about 1 in 10 people can't take metformin. And nobody really knows why. So we've been interested in that. And you think 1 in 10 people can't take it, maybe it's something genetic, and that's what we were assuming. So we've been looking at the genes involved in how metformin is transported across the gut. And there's 8% of us who carry genetic variants in a gene called OCT1, which is one of the main metformin transporters, that means that you just don't take metformin up. You don't transport it. In fact, what happens is you probably concentrate it in the gut. And we showed that those 8% of us are about twice as likely to get metformin intolerance. But more than that, there's many drugs that we take that also act on this channel. So if you're taking, like most of us are, omeprazole or lansoprazole, one of these proton pump inhibitors, or antihypertensives, antidepressants, a whole load of drugs, these interact with the same transporter. So if you're on, say, omeprazole, and you're the 8% who's genetically prone to get it, you're over 4-fold more likely to get GI intolerance. So we can't change our genes, but we can change our treatments that we're on. So people who get intolerance with metformin should probably look at their medication that they're on and see whether or not anything is interacting with that treatment. You may be the unlucky 8% who has the intolerance genes. You may be the 8% who could actually do something about it with their treatment. Okay, so what have I told you? I've told you that precision medicine is targeting therapy based on simple stuff, weight, BMI, and clever stuff, genetics, okay? I've told you that diabetes has been majorly oversimplified and that we're making progress in unravelling the genetics of drug response. And Dundee, I have to say this, I would say this, but Dundee is leading the way in this area hugely. And it's leading the way because of the people of Tayside. So 17% of the Tayside population have signed up to give DNA and allow us access to anonymised medical records to do this sort of research. 17% of the Tayside population. And I'm going to finish with one 1-minute plug, which is for Share. And there is an initiative now which I would encourage you all to sign up for if you haven't already. And this is to go beyond that 17%. This would be to try and get as many people in Tayside and Scotland signed up for a research register. This is a research register that means that you say, I'm happy to be contacted around research studies. You don't have to agree to them, you're just happy to be contacted. And actually, more excitingly, it's where you consent to have any spare blood that's left over after a blood test that would otherwise be thrown in the bin, used for research. So you can link the blood tests to all of the medical data we have, and that's how we can really much greater understand how to be much more precise with how we manage diabetes. I've got a whole load more stuff I should say, but I won't, and I shall stop there. So thank you very much for your attention.